Thanks for coming. I know on Saturday you guys could have a lot of things that you might prefer to do. And I hope that in the next 30, 35 minutes I give you some valuable information that you can use in your own healthcare discussions with your personal physician. What I was asked to talk about is just screening. You know, there's a lot of things that we can screen for today. Which ones should you be most interested in? Which ones should you not be interested in? Why? And I'll give you really not my own personal thoughts as much as these are official recommendations from the organization that makes these assessments for physicians in the United States. So we'll talk a little bit about that body. It's called the United States Preventive Services Task Force. It's a non-political, non-elected, representative group of physicians who look at all the evidence that's been published about a particular screening test and issue guidance to physicians in the United States. And I'll specifically cover what they say about vascular, cardiovascular screening, respiratory or lung disease screening, cancer screenings, diabetes and obesity, HIV and glaucoma, and then one little slide at the end to talk about which vaccinations are recommended for men at your age. This is my own disclaimer. This is not because a lawyer told me to write this. This just is a deeply held belief of mine. I really believe that medical decisions should be made between you, the patient, and your individual treating physician who has taken responsibility for your care. The content of this talk really should be considered not to be a substitute for those kinds of discussions. It's really an information opportunity for me to give you information so that you can have better communication with your doctors. So the USPSTF, the United States Preventive Service Task Force, makes recommendations on clinical preventive services to primary care physicians in the United States. Screening tests, counseling, and preventive medications are their area of expertise. They only make recommendations on services that can be offered in a primary care doctor's office. They're not going to make in-depth decisions about what happens in specialty level service areas. And importantly, these recommendations that I'm going to talk to you today are about patients who have no symptoms. This is true screening. Now, if you have a symptom and you're going to a doctor, you're not doing screening at that point, you're doing diagnosis. So what I'm going to tell you today is for the man who feels fine but is going to a doctor for a checkup. This group makes recommendations based on a very rigorous review of the published data. Now, in some areas, there's not published data, and in that instance, your doctor has to make an informed decision and his best guess. But where there's evidence, they make strong recommendations, and I'll talk to you about that in a minute. When they make these recommendations, they're always balancing the benefit versus the harm. So what's the benefit of the screening that can be measured, and what harms come from that screening? Either danger to the patient or misdiagnosis or exposure to unnecessary tests, some of which have side effects. And it's really an independent panel. So this panel is free from any of the tethers that tie many folks up in Washington, D.C. So what they do is they make a letter recommendation. And you'll see throughout my talk, this is a grade A recommendation or a grade B recommendation. Grade A is they highly recommend the service because there's clear benefit there's clear evidence that there's more benefit than harm from a particular test. Grade B, they also generally recommend it because although the data is not quite as robust as it is for level A, it's still enough to suggest that there's at least a moderate chance that it's a good thing to do. C means in general you shouldn't do it, but there may be selective patient types where it may make sense. So that's one where the doctor really has to think about the patient they're seeing and make a judgment. D means they do not recommend the service, that there is significant data to suggest that the service creates more harm than benefit. And I, incomplete evidence, means they just can't really say. It's a new test or there's just not enough information to make a decision one way or the other. So this is the grading system as we go through the talk. Well, why do we need that kind of an organization? Well, I don't need to tell anybody in here, healthcare costs are rapidly escalating in the United States. In the last 10 years, the average American family's out-of-pocket expense for healthcare has doubled in 10 years. We can't continue along that curve. None of us will be able to afford healthcare insurance. Most healthcare providers, such as myself, operate in a payment system that rewards testing and procedures. The more things I do, the more I get paid. So that's a bad incentive, right? Because now I don't necessarily have a vested interest in selecting tests that only have high value, because I get paid the more stuff I do, and that's how most doctors in Louisiana operate today. I don't mean to say that most doctors take advantage of that knowingly or willingly, but the alignment between payment and testing suggests the need for more tests in most cases. Many tests and procedures are performed out of concern for malpractice liability, not because the doctor really thinks it's the right thing for you to do, but he's covering himself so that if something very rare was at play and he missed it, that he has some liability coverage there. The Congressional Budget Office in Washington estimates that about a third of the care provided in the United States is unnecessary. So if you think about the fact that we're spending about $2.5 trillion on health care, and a third of that maybe goes to unnecessary treatments and testing, if we could cut that down, we may go a long way to reducing health care costs. Patients, providers, and payers need to define and provide for high-value services. And there's so many things that can be done to you today that you need to be educated so that you can ask the right questions of your doctor when he suggests a screening test for you. Just to know that it's not just the United States Preventive Services Task Force that's doing this. A lot of medical societies have now issued, in conjunction with Consumer Reports, a list of their top 5 services that their doctors should stop doing routinely. And I'm just going to give you a flavor of this. The American College of Cardiology has said, hey, cardiologists, we should not perform stress testing or nuclear imaging in the initial evaluation of a patient unless they have very alarming symptoms. And we shouldn't perform annual stress testing or nuclear imaging for most patients who don't have symptoms. And yet a lot of cardiologists do an annual stress test as just part of a routine physical. Their own college has said we need to stop doing that. The American Academy of Family Medicine says we shouldn't do x-rays or MRI for back pain within the first 6 weeks, except for very rare occasions, fever, trauma, a person who has cancer, where you might be worried about a serious problem. But I can't tell you the number of patients who call me up and say, my back's been hurting for 2 days, can we get an MRI at about $1,500? We shouldn't be prescribing antibiotics for mild to moderate sinus infections unless the symptoms have been present for over a week and are worsening. And yet a lot of times we as physicians, to feel like we're doing something for patients, will give them an antibiotic 2 days into an illness. We shouldn't order annual EKGs in low-risk patients. How many people go see their doctor for a physical every year and have an EKG as part of it? And that's really not something that's recommended by the American Academy of Family Medicine. The Gastroenterology Association, okay, the GI guys who do colon cancer screening, well, they've been told we shouldn't repeat a colonoscopy for at least 10 years after a normal colonoscopy if that normal colonoscopy was a high-quality study, that we shouldn't do any other screening for that for 10 years. And we shouldn't do it for at least 5 years if you have small polyps. And there's a lot of doctors out there who do screening colonoscopies every 3 years or at a shorter interval. So again, there's room for us all to improve. And then finally, allergy, asthma, immunology. Their college said of the top 5 things their doctors could do to save money: stop ordering CAT scans of the sinuses for everybody with sinusitis, stop prescribing antibiotics for uncomplicated sinusitis, don't do a big workup on someone who comes to see you for hives. I mean, we've all had maybe an episode of hives, and it doesn't require, in most cases, a sophisticated, expensive workup. And asthma, patients shouldn't be diagnosed or told they have asthma unless they've had a formal breathing test. Just based on their symptoms of I occasionally wheeze, we shouldn't call someone asthmatic and put them on medications that they'll take forever to control asthma unless we've proven it. So just to give you a flavor that this is a big deal in medicine now. All of us are starting to look at where we're wasting money, and we're trying to get to an area where we're spending the few dollars that we have on real high-value services. So this isn't rocket science, right? Intellectuals solve problems, but geniuses prevent them. And I applaud y'all for being here, because women actually in the United States are twice as likely to go to see a doctor for a preventive health service than men are. Most of us will have to be dragged in unless we can barely walk or breathe. And so I want you all to know that I really feel strongly about preventive care. So what do we die from? This is kind of hard to read, and we're not going to get into the weeds here, but women are on the right, men are on the left. Obviously, the two big ones, if I can figure out how to use this laser pointer here. The two big ones are heart disease and cancer, and there's a little bit more death from heart disease in men than there is in cancer, but those two account for about 50% of all deaths. Unintentional injuries, so accidents, trauma, stroke, diabetes, and then a variety of things. Alzheimer's, only about 2% of men die of Alzheimer's disease. So that's kind of what we die from, but really I think we can boil it down to the 5 major preventable killers, and this is where I'm going to focus a lot of my talk today. Diabetes, lung disease, stroke, cancer, and heart disease. These 5 account for about 75% of avoidable deaths in men, and that's really where we should focus our efforts. Let's start with cardiovascular disease, since it is the primary killer of men in the United States. There is a definition of optimal cardiovascular health, and it means that if you want to say that you are in optimal cardiovascular health, you have to meet all of these criteria. You have to be a non-smoker. You have to be physically active, meaning that you partake in at least moderate intensive exercise most days of the week. You have to have a blood pressure of less than 120/80, a fasting blood sugar of under 100, a total cholesterol of under 200, an ideal body weight, which is a body mass index of under 25, a BMI of under 25. You have to eat enough healthy fruits and vegetables in your diet. And if you do all those things, you are at optimal cardiovascular health. Currently in the United States, only 1.2% of adults are in optimal cardiovascular health. And it's a shame, because if you're in optimal cardiovascular health, you have a 76% reduction in heart-related death and a 51% death of dying from anything. So that is what we should strive to get to. Now, it may seem like pie in the sky, but there are people who are able to do that. So the first screening that I think we'll start with, and I think probably if you came to a primary care doctor and he could only do one thing for you, it would be to check your blood pressure accurately. This is probably the one thing we can do as Americans to avoid the most chronic illness, and that's to have our blood pressure controlled. And because blood pressure doesn't make you feel bad typically, you really have to measure it to know if it's abnormal or not. It should be checked at least every 2 years if it's normal. Normal is less than 120/80. If it's pre-hypertensive or borderline hypertensive, between 120 and 139 and between 80 and 89, it should be checked every year, at least once a year. And the goal is, if you need to be treated, that you want to keep your blood pressure less than 140/90 for most of you. There may be a couple people out there where we would actually want it lower than that, but for the vast majority of men, I would say if your blood pressure stays in the 130s over the 80s or less, you're doing pretty well, and we can live with that. This can be monitored at home. You can get a home blood pressure monitor. However, you need to make sure that you have one that's accurate, and you have to have it validated by a doctor in his office to make sure that it's accurate. And then you have to know how to use it correctly. And I don't want to get into it today, but it is something that I think people should be able to monitor at home. So just like they would be able to monitor their temperature or their weight at home, blood pressure is something I think we need to start paying more attention to. The USPSTF gives this a grade A. This is a no-brainer. All men should do this at least once every 1 or 2 years. What about a 12-lead EKG, where they hook you up to an EKG, or a stress test? Should that be part of a routine screening? The USPSTF says no, grade D. There's no reason for most asymptomatic patients to have these tests on a regular basis. So if your doctor says you're 50, it's time to do your first stress test, there's really just no evidence for that in most people. Now, I will say this, if you're a patient who's at moderate or high risk for cardiovascular disease, maybe you're overweight, maybe your cholesterol's high, maybe you smoke, there the level of evidence is a little bit inconsistent and I would say incomplete, and that's where judgment has to be at play with your physician. So the question is, how do you know if you're at moderate or high risk or low risk? Well, in the United States, doctors are encouraged to do what's called a Framingham risk score. It's something where you take your age, your gender, your cholesterol, your smoking status and your blood pressure, and you put it into a formula, and it calculates your 10-year risk of having a heart attack. And if your risk is less than 10% over the next 10 years, you're at low risk. And if your risk is between 10 and 20%, you're at moderate risk. And if it's over 20%, you're at high risk. And that should determine what screening tests you have at your doctor's office. And there's a website. You can go online and just Google Framingham Risk Calculator, and you can do this electronically. What about lipid or cholesterol testing? Well, grade A evidence here. This is another one that's a no-brainer. Men 35 and older should undergo cholesterol screening probably every 5 years. If it's abnormal, it probably should be every year. If you're under treatment, it should be at least once a year. Men aged 20 to 35 with risk factors should probably also undergo risk screening, meaning family history of heart disease, smoking, high blood pressure, high cholesterol, physical inactivity, obesity. This is what you're looking for. Total cholesterol, optimal, is under 200. LDL, or so-called bad cholesterol, for most people, under 130 is okay. 130 is the average LDL in the United States for an adult, so if you're below average, that's generally good. For patients who are at high risk, so this would be somebody who's got diabetes, or somebody who has multiple cardiovascular risk factors, the goal for that person would be 100. And if you actually have heart disease, if you've had a stent, if you've had a heart attack, if you've had bypass, the goal is actually now to reduce your bad cholesterol to less than 70, which is quite low. It's about the second percentile for the population. Very aggressive goal in the United States. HDL, or so-called good cholesterol, the goal is to be above 40 for men. And triglycerides, which are really driven up through being overweight, drinking too much alcohol, or eating too much sugar and starches. That's really what drives triglycerides high. The goal there, optimal, is to be under 150. What about carotid artery ultrasound? Giving you a nice picture of your carotid artery. Many of you may have heard of Lifeline screening. They'll come out to a community center or church for $150. They'll do a variety of vascular screening tests, one of which is to look at your carotid arteries for plaque buildup. The United States Preventive Service Task Force says we shouldn't be doing this. There's just no evidence to suggest that this is a good use of money. The general adult population should not have this test performed in the absence of neurologic symptoms, meaning a threatened stroke or a mini stroke, or clinical evidence of a blockage. The doctor listening to your carotid artery and hearing a narrowing, hearing blood swishing through a narrowing, or not being able to detect a pulsation in your neck. Those would be reasons to do the test. But just somebody who's interested at age 50, there's just absolutely no evidence to suggest this is something we should be doing routinely. What about abdominal aortic aneurysms? Okay, you all, this is the aorta, here's the kidney, so a dilation of the aorta, that ruptures, most people die. So there's a lot of interest for some people in screening for that. We usually screen for it with an ultrasound. Well, there is a group of people where actually this does make sense. If you're between the age of 65 and 75 and you're a man, you should have this screening once if you were ever a smoker. So that's the one group of men where this probably makes sense. There's enough evidence to do that. So 65 to 75, ever smoked, you should talk to your doctor about having this screening. Really, there aren't any significant recommendations they made for men between 65 and 75 who've never smoked. They gave it a grade C. What they basically say there is, look, if there are multiple men in your family who all had abdominal aortic aneurysms and you didn't smoke, maybe that would be a group of people you'd want to screen. But in general, non-smoking men have such a low risk of aneurysm that it's probably not worth the money that we're spending on that test. Peripheral arterial disease screening. Peripheral arterial disease is blockages in your leg arteries. We call that PAD. You may have heard, there's a lot of ads on the radio and about this. And basically, PAD, the way we normally screen for this in the United States is we put a blood pressure cuff on the arm and on the ankle, and we measure, and we look at the ratio of the blood pressure in the ankle compared to the arm. They should be roughly the same. If the blood pressure in the ankle is substantially lower than that in the arm, it suggests blockage in your leg arteries. The problem is that people who don't have any symptoms probably shouldn't have this done. Not worth it. what are the symptoms? Well, if you have significant blockages in your leg arteries, when you walk, you will typically start to get a burning sensation either in your buttocks or down in your calf. And when you stop walking, within a minute or two, it goes away. And then you walk some more and it comes on again and it stops. Those people should have this testing done, because now you're looking to see if you can confirm that they have a blockage, to see if there may be a procedure they need to relieve that blockage. But for asymptomatic people, it probably doesn't make any sense to have this test done on a routine basis. They do it laying down. Yeah. Good question. Lung diseases. All right. Clinicians should ask all men about tobacco use and provide counseling on stopping and provide medications to help them stop. That's grade A. Again, kind of a no-brainer. So that's something that's easy. It's just a question. But it's a little bit difficult to know what else we should do to people who smoke to screen them for lung cancer. The USPSTF says there's insufficient evidence to recommend for or against screening for lung cancer with routine chest x-rays or CAT scans of the lungs or what's called sputum cytology, where you get guys to cough up some mucus and you look at it under the microscope to see if there's any cancer cells in it. There's really kind of grade I here, grade I, incomplete evidence. Now I will say, recently, much more recently than this recommendation, the American Cancer Society and others has issued recommendations for using a low X-ray dose, low radiation dose CAT scan to screen for lung cancer in men and women aged 55 to 74 who've smoked 30 plus pack years. How do we calculate a pack year? If you smoke a pack a day for 30 years, that's 30 pack years. If you smoke 2 packs a day for 15 years, that's 30 pack years. So if you've smoked over 30 pack years and you're between the ages of 55 and 74, there are a large number of medical societies now who suggest low-dose CAT scanning is effective at detecting early lung cancer and might be reasonable to consider. What about colon cancer screening? All my patients just love this test. They line up for it. They want it. Actually, it's a grade A recommendation, so this is one of those that we really should be doing. Men aged 50 to 75 should have screening for colon cancer. And the USPSTF says there's at least 3 valid ways to do this. Checking your stool for occult blood meaning blood you can't see with the naked eye but that we can detect chemically, every year is one way you could do this. Doing a flexible sigmoidoscopy, or my patients call that the short scope, the one that's done in the office without sedation. It's about a 35 to 40 centimeter flexible scope. We go in the rectum and we look at the sigmoid colon every 5 years, or a full colonoscopy where you get sedated and they have a longer scope that's run through your entire colon. That should be done every 10 years. Now, my personal preference is, if you've got insurance to do it, that the colonoscopy really in today's world is the preferred method, because it's the only method that approaches about 90% accuracy. There's a lot of false positives. There's some food substances and things that can cause the blood test and the stool to be abnormal, so then you got to go do another test anyway. There are also patients who have large polyps who don't bleed, where you don't detect them and they could develop cancer. Flexible sigmoidoscope looks at only a short part of the colon. You can miss other areas of the colon. So I really do think colonoscopy is the way to go, but for someone who doesn't have good insurance, at least doing this would be better than nothing. Now, what the USPSTF says is that most men over 75, most men probably don't need colon cancer screening, and for sure they would discourage it after age 85. The reason is you've got to have a long enough life expectancy for any screening test to be worth any risk. And so since there is risk to colonoscopy of perforating the colon, etc., or bleeding from a biopsy, you don't want to do that if there's not a significant chance that you're going to live long enough to reap the benefits of the test you're actually performing. So in general, I discourage my men over age 85 to go through colon cancer screening. Now, there are some newer tests that are out. Virtual colonoscopy is done with a CAT scanner. It's not covered by most insurance companies, and it's several $100s. And then there's a new stool test where they look for DNA that is shed by colon cancer or polyps. So that these tests might have a growing place in our armamentarium to screen the many men who don't want to have colon cancer screening. But there's just not enough evidence right now for us to make a clear recommendation to you. But I think there's a lot of research in looking at other ways, because the fear of doing a colonoscopy is such a huge barrier for men to have the appropriate screening test done. And it's really a shame, because probably 85% or more of colon cancer really is preventable through appropriate screening. Which one? The virtual? A colonoscopy? Depends. It really depends who's doing it and how they're sedating you. You know, it can range anywhere from about $1,200 to $3,500. Some people use anesthesia folks, certified nurse anesthetists, to use like propofol, kind of Michael Jackson stuff that he was using to sleep. They'll give that because you get into a much deeper sleep and they can wake you up very quickly. But that adds cost too, because now you're paying someone to administer and monitor anesthesia. Doctors who use the old-fashioned Demerol and fentanyl or Versed, it may be cheaper, but you just have to talk to the doctor who's doing it and see. I can't give you a single number. Pancreatic cancer. Everybody knows somebody who's had this. This is an awful cancer, because almost everyone dies of it unless you accidentally find it when you were looking for something else and you see a tiny little spot in the pancreas and can do surgery. Once pancreatic cancer causes symptoms, you're not going to survive generally. And there's about 30,000 deaths from pancreatic cancer in the United States every year. So it would be nice if we could screen for this. Unfortunately, we don't have a good screening test. And as of right now, the USPSTF gives grade D to recommendation for screening for pancreatic cancer. So CAT scanning, ultrasound, or blood tumor markers really aren't ready for us to employ them to the population at large. So I think this is one that we just have to hope we don't get, but there's not really a good screening test for this. Cancer screening, skin cancer. All right. Officially, the USPSTF says, you know what, we just don't have complete evidence to say whole body skin exam by a primary care physician or a patient is worth doing. We also don't have any clinical studies that say for sure that jumping out of an airplane without a parachute is bad. There's no risk really, and there's no pain, and there's really no cost in having your primary care doctor check your skin out for skin cancer. So I don't want anyone to walk out of here and suggest that I told you it's never worth having someone look at your skin and check some moles out for you. It's just that there's not a lot of evidence in the literature for them to make a significant recommendation that all adults go do this every year. Now, it probably does make sense for young men, children, adolescents, and young adult men, aged 10 to 24, to go at least be counseled about sun exposure, because most of the risk of skin cancer that we accrue later in our life is due to the sun exposure we get when we're young. So the time where we have to protect ourselves is really those years where we don't care. It's right. It's when we're 12, 13, 15 years old and we're outside all day with our shirts off. That's the time when our skin is being damaged the most. And there's also insufficient evidence to balance the benefits and harm of similar counseling for patients older than 24. So although I tell my patients with fair skin, make sure you're wearing a hat, make sure you're wearing sunscreen, the evidence doesn't suggest that's a good use of my time, but I choose to do that because it takes me about 20 seconds. The most controversial thing I'm going to say today is that the USPSTF now says you shouldn't get a PSA. And there's a doctor who's a good friend of mine in another room right now telling you should absolutely go get a PSA. And he's also talking about robotic surgery and some of the high-tech stuff that we have for prostate cancer. I just want to go through the understanding of this because this is a big deal and this is new. I mean, really, this guidance was issued in May of 2012, and it has really shaken up internal medicine and family medicine, because for the last 30 years or 25 years or more, PSA testing has been kind of a standard thing we do really without thinking too much about it for most men. Right now, the USPSTF gives this grade D recommendation, meaning most average risk men without symptoms should not have PSAs anymore. And let's talk about why. Well, here's the co-chair of this organization and what he said about it when they issued this. Quote, and I'm going to read because this is important. Prostate cancer is a serious health problem that affects thousands of men and their families. But before getting a PSA test, all men deserve to know what the science tells us about PSA screening. And that is there's a very small potential benefit and significant potential harms from doing it. We encourage clinicians to consider this evidence and do not screen their patients with a PSA test unless the individual being screened understands what is known about PSA screening and makes the personal decision that even though there's a small possibility of benefit, okay, even though that's true and that the risk of harm is significant, that he still wants to have the testing done. It's a blood test. It shows you what your level is and so forth. Yeah. So let's talk about the downside. They looked at all clinical trial data, and there's actually a significant amount here. What they found was that compared to not doing PSAs, doing PSAs led to very little impact on your risk of dying from prostate cancer over 10 years. So number one, doing it versus not doing it doesn't largely change your risk of dying from prostate cancer. So that's number one. Number two, there's about a 12 to 13% false positive rate, meaning that the PSA is elevated, but you don't really have cancer. Okay? There's about a 1% chance of serious complications from biopsying the prostate. I've had a couple of patients of my own this year be admitted to the hospital with a serious bloodstream infection within 24 hours after having their prostate biopsied. It is true and it is undeniable that there are more cancers detected with PSA than if you don't use PSA. The problem is the vast majority of prostate cancer will not impact how long you live. That even if it's never detected or left untreated, most prostate cancers grow so slowly that they're not going to kill you. And so there's all this treatment, surgery, which can lead to incontinence and impotence, radiation, hormonal therapy that affects your quality of life, where we're doing something because of a PSA being high or even because we've detected cancer, and we're just not sure yet which ones of these patients should be treated and which ones shouldn't. Now, this is incredibly controversial. I haven't even had time to get my own head around this, so I'm not going to leave you here with this message alone. I want to balance it by what the American Urologic Association says. Now, granted, this is the association that represents all the urologists. So what happens when your PSA is high? You get sent to a urologist. So you've got to understand that they're going to be very concerned that we don't tell that doctors don't start telling every patient, stop screening for prostate cancer. That's of concern to them. And they have some valid concerns. They seriously disagree with this recommendation. I mean, they were very upset about this. They think this is bad for men. They cite their own evidence that shows marked reduction in metastatic prostate cancer since the introduction of PSA testing. There's a lot less metastatic prostate cancer today than there was in the past. And they believe it's because men are being detected at an earlier age through PSA testing. They're really concerned that the message sent by the USPSTF is really bad for high-risk groups such as African Americans, who we know have a higher risk of prostate cancer than their Caucasian counterparts. And they believe that the PSA, though imperfect, and they admit it, it's not a perfect test, is still the best test we have until a more specific test is created to detect early disease. So I can't tell you what to do. I think that what you should do is just have your own discussion with your doctor. And I think that what I've started to do is, instead of just throwing in a PSA as a routine part of the health panel, I really want to have a discussion with the doctor about that before we do it. Many guys are still choosing to do it. I mean, this is ingrained in healthcare for the last 30 years. And there'll be people here today talking about we should still be doing it. So I think this is new information that we have to digest. So at least I want you to know that there's controversy about it, and I think it's a good thing to talk to your doctor about. Aspirin. I get asked a lot, should I be taking a baby aspirin or not? Well, grade A recommendation, pretty much men aged 45 to 80 should probably be taking a low-dose aspirin. That's 75 to 161 milligrams, so half of a full aspirin or less. If the potential reduction in heart attack or MI outweighs the risk of GI bleeding. So somebody who's had 2 hospitalizations for a bleeding ulcer probably shouldn't take baby aspirin. On the other hand, someone who smokes, has 3 guys in his family who've had heart attacks at age 50, who's overweight, has high blood pressure, and has high cholesterol, probably should take a baby aspirin. There's very little evidence for men under age 45 when it comes to aspirin. So I would say if you don't have really any history of stomach problems or stomach bleeding, and you have any other risks for heart disease beyond being a man, then I'd probably err on the side of taking a baby aspirin to reduce the chance of having a heart attack. Men 80 and above, we just don't know what to do with them. I mean, there's an increased risk of bleeding above 80, but there's also an increased risk of heart attack, and so I think you just have to make individual judgments for men above 80. What about vitamins? We spend a lot, yes sir? I would not start aspirin if there's blood in your stool until you've been cleared by a GI doctor. You should definitely go see the GI doctor, because a lot of colon cancer or colon polyps won't bleed until you start taking your aspirin, and then you'll detect it. And so actually it's one of the reasons I tell men to take aspirin, is that it may uncover some underlying illness that we wouldn't have known about had they not been on aspirin. Does that make sense? Vitamins. This is really easy. There's very little data that we should be taking lots of vitamins. Okay? I mean, I think men and women like spend a lot of money on vitamins because it just seems like it's a good thing to do and it's natural. There's probably incomplete evidence to recommend for or against vitamin A, C, E, folic acid, or antioxidants to prevent heart disease or cancer. So they're not going to tell you don't do it, but there's just not great evidence one way or the other. There is good evidence that we should not use beta-carotene supplements, especially if you smoke, because your risk of lung cancer goes way up if you take beta-carotene as a supplement, especially if you're a smoker. I don't really recommend routine vitamin therapy for most of my patients. Carotene? It's called that. It's what it would say. It would say beta-carotene on the bottle. Yeah. I don't. No. I mean, I still think, for me, a multivitamin should be taken by someone who has a really poor diet. I mean, someone who doesn't eat 3 meals a day, who doesn't really include fruits or vegetables in their diet, then a multivitamin may bridge the gap between some of those micronutrients you're not getting in your diet. So if you work shift work, you eat erratically, you frequently are having to eat fast food, you're just not in a good place with your diet, taking a multivitamin may be a good idea. Fish oil is a whole different topic. There are groups of people where fish oil makes sense. I'll just say the American Heart Association says if you don't eat salmon or halibut or mackerel or tuna, and all you eat is redfish and trout and snapper and the stuff we eat down here, that it would be reasonable to take a fish oil supplement because you should have a couple of servings of healthy fish a week. And if you don't do that, taking a fish oil supplement to give you healthy omega-3 fish oils is a reasonable thing to do. But when I get through, if there's specific questions about that, I'll address them. Diabetes screening makes sense if you've got moderately elevated blood pressure. So if you don't, there's really no great evidence, but it looks like that in men especially, having higher blood pressure tends to really correlate with your risk for diabetes. And so the USPSTF says, yeah, there's pretty good evidence that if your blood pressure's over 135/80, kind of on the higher end, it's probably worth having screening for diabetes as well. If your blood pressure is completely normal, there's really just no evidence for the average population who has no symptoms to be routinely screened for diabetes. If you are going to be screened, you need to know what normal is, right? So if you do a fasting blood sugar, you come in the morning, you haven't eaten, haven't had anything to drink, and you do your blood sugar, normal is under 100, diabetes is over 126, and in between is what we call prediabetes. Right? If you do a random blood sugar, meaning just out of the blue, you could have eaten or not, if it's over 200 and you have symptoms of diabetes, excessive thirst, excessive urination, unexplained weight loss, extreme fatigue, and someone just randomly does your blood sugar and it's 240, you probably have diabetes. And if you were to check your blood sugar 2 hours after a meal, normal's under 140, Diabetes is over 200, and pre-diabetes is between 140 and 200. Some of you may have heard about a blood test called the hemoglobin A1C. It's a blood test that tells you on average how your blood sugar has done over the last 3 months. Normal is less than 5.8%. Diabetes is greater than 6.5%. So these are the ways that we can screen for diabetes in the United States right now. Obesity screening, grade B, all adults should be screened for obesity, and it's usually done with a body mass index where they take your height and they plot it against your weight, and you're either optimal weight, overweight, or obese. Again, a BMI of 30 or greater is obesity. 27 to 30 is overweight. Under 27 is considered reasonably good weight. And these tables are widely available, and there are probably some out there in the exhibit hall, is my guess. HIV screening. Baton Rouge, for many years, I don't know if this is still the case, leads the United States in new cases of HIV. We're the worst. There are more new cases of HIV in Baton Rouge than any other city in the United States. At least that was true a couple years ago. Per capita. So the USPSTF says there is grade A evidence for screening for HIV if you fall into a high-risk group. Any man who's had sex with another man after age 1975 should be screened. Unprotected heterosexual contact with multiple partners, usually 3 or more, should be screened. Past or present injection drug users should be screened. Anybody who has either sold sex or bought sex should be screened. Individuals whose past sex partners were HIV infected, bisexual, or injection drug users should be screened. Any person being treated for another sexually transmitted disease should be screened for HIV. And anybody who got a blood product transfusion between 1978 and 1985 should be screened. So none of these apply. There's no reason that you should run out and ask your doctor for an HIV test unless you just have to know. But if you fall into one of these risk groups and you've never been screened, you should. Glaucoma screening, just not enough evidence to tell every adult man to run out and get screened for glaucoma. If you need to go to the eye doctor anyway for glasses or some other reason, they'll do it. But it's not something where I make people spend their money to go get glaucoma screening unless they have a family history of glaucoma or they take certain medications that could be a risk if they have undiagnosed glaucoma or they've had a rapid change in their vision, etc. So grade I evidence right now. So to summarize kind of what USPSTF says do is check your blood pressure, check your cholesterol, get screened for abdominal aneurysms if you're over 65 and you ever smoked. Screen people. You should ask patients about tobacco use and offer them counseling and drugs to stop. Colon cancer screening start at age 50. Aspirin at age 45. Diabetes screening, especially if your blood pressure is high. Obesity screening and HIV screening if at high risk. We should all do that at least. Maybe aneurysm screening for men over 65 who never smoked if there's a family history of aneurysm. Maybe colon cancer screening for really healthy 76 to 85-year-old men. Who knows? EKG or stress testing in asymptomatic patients at moderate or high risk for heart disease. Screening for lung cancer with chest x-ray, low-dose CT, or sputum cytology. Maybe the isolated group of people with 30-plus pack-year history should have CT scanning. Colon cancer screening with some of the newer tests. Routine whole-body skin exam by the primary care physician. Diabetes screening if normal blood pressure, aspirin use in men over 80, and multivitamin use. Not really enough evidence to make strong recommendations. And what we probably shouldn't be doing routinely, at least according to the United States Preventive Services Task Force, is EKG or stress testing in asymptomatic low-risk men, carotid artery ultrasound, PAD testing, colon cancer screening after 85, screening for pancreatic cancer, PSA-based prostate cancer screening with the caveats that we mentioned, beta-carotene supplementation, and glaucoma screening. Finally, a word about immunizations. There's just a few that you need to know about. Every man, no matter what age now, should have a seasonal flu vaccine. Every fall, usually September, October, November, somewhere in that time frame. We should all be doing that every year, all ages. Tetanus, diphtheria, pertussis, tetanus booster every 10 years. But at least once in your life, you should have what's called Tdap, which is tetanus, diphtheria, and pertussis. Pertussis is whooping cough. There has been a resurgence in whooping cough in the United States because people have not kept up with this vaccination. And if you're a small child, or you're a grandparent to a small child, or a parent to a small child, they can get very sick with whooping cough, and we can give it to them. So we want to make sure that we have that taken care of. Zoster or Zostavax, the shingles vaccine, should be done at least once after age 60 if you've ever had chickenpox. If you've never had chickenpox, you should have vaccination against chickenpox. If you don't know, you should have a blood test to confirm whether or not you've had chickenpox. And if you've had it, I would recommend getting a shingles vaccine after age 60. And finally, pneumonia vaccine, Pneumovax, once after age 65 for everybody. There are certain high-risk groups like people with asthma, emphysema, diabetes, heart disease, and cancer who should get Pneumovax much earlier in life. And in that case, they need one more at age 65 or 5 years after their first one. But no one needs more than two. And there's a lot of doctors who give all of their adult men a Pneumovax every 5 years. And that's not necessary. You don't need to do that. So with that.